Okay, so good evening, everyone. My name is Ahmed Ghanem. I'm a surgical trainee and the BOMSS trainee representative. Welcome to this evening BOMSS Journal Club. It's the 9th of April 2025, and am I delighted to have the bariatric team from University Hospital Lewisham with us today. As usual, these sessions are recorded, and those who didn't manage to attend can view them on the BOMSS official channel on YouTube. May I ask everyone to post your questions and any comments under the Q&A button, and we will answer those questions during the Q&A session. Now over to you, Mr. Mamedana. Thank you again for hosting this event, and if you would like to introduce your first speaker, please.
Good evening, everyone. I'm Ravi Mamedana, Upper GI Bariatric Surgeon at Lewisham Hospital. Thank you to BOMSS for giving us this opportunity this evening. So first we have the IHP paper, which is going to be presented by Olivia Painter, who's our assistant psychologist. We all know the importance of the role of a psychologist in preoperative assessment, but she's going to talk about the role in outcomes and the implications in the postoperative period. When you're ready, Olivia, if you want to share your screen.
Thank you, Ravi. Let me share these slides. Okay, good evening, everyone. Thank you for having me today. As Ravi said, my name's Olivia and I'm an assistant psychologist in the team at Lewisham. And today I'm going to be talking through this paper on weight loss and regain after bariatric surgery, the importance of psychological therapy in postoperative outcomes. So this is the paper. It was published in Obesity Surgery in January of this year, and the journal Obesity Surgery has an impact factor of 3.3. And this data was collected in Argentina. And as Ravi highlighted, the reason we chose this paper is because it focuses on psychological therapy, particularly in the postoperative period. And generally within practice and also within the NICE guidelines, there's a real focus on that preoperative assessment period and identifying psychological needs that, if met, would help ensure the suitability of surgery. But there's not a lot of information and focus on what should happen postoperatively with patients in terms of psychological support. So we felt that this was a really important and timely paper to consider. And throughout this presentation, I'm going to be taking a critical lens to really help you think about the scientific integrity of this paper. And towards the end of the presentation, I'm going to highlight what we feel are some of the strengths and limitations. So the background of the paper, as you all know, bariatric surgery is proved to be the most effective tool for obesity control, with weight loss reaching its peak between 8 and 14 months after the procedure. However, success gratefully depends on patients making behavioral and lifestyle changes, with behavioral and psychological aspects therefore representing risk factors for weight regain in patients who have successfully lost weight. And I found this quote quite interesting. So the paper is suggesting the idea that the therapeutic labor of the bariatric psychologist will be reorientating and accompanying patients to achieve a higher adherence to treatment. I'm not sure what some of the bariatric psychologists in the room might think of this quote. When we discussed this, we thought that although it's highlighting a really important area of a psychologist in terms of supporting adherence to treatment, it's perhaps taking a bit of a narrow view of psychology and missing the kind of wider importance of a psychologist in terms of thinking about supporting patients to adjustment and also their mental health outcomes. And this paper also suggested that 12 months is recommended as an adequate psychological follow-up period. I'd just like to note that they didn't provide any citation or justification for this idea of 12 months being recommended, but that's what they're suggesting nonetheless. So the objective of this study was to demonstrate the importance of psychological postoperative accompaniment in weight loss and regain in patients who underwent bariatric surgery. And Typically, when we would think about putting together a research objective, we would take a bit more of a curious stance. So in this case, we would explore whether psychological postoperative accompaniment is important in weight loss and regain. So they've made quite a strong statement here that they want to demonstrate the importance, which could potentially be seen as bias. And also this idea of the psychological postoperative accompaniment is quite a vague explanation of the intervention that they're trying to explore here. So this is perhaps not the best operationalized research objective. So if we move on to the methods, the researchers retrospectively analysed a general database and medical records of an Argentinian institution, and they also conducted telephone surveys to supplement any missing information. So 100 patients who were aged 18 to 70 and had bariatric surgery between January 2016 and September 2021 were included in the study, with the only exclusion criteria being pregnancy. And they were looking at the predictor variable of postoperative psychological follow-up, so whether patients had this or not. And their outcome variables were weight, percentage of excess weight loss, and percentage of weight regain. And if we look at that predictor variable a little bit more closely in terms of the psychological intervention, the paper reports that preoperatively, patients had at least 4 sessions of psychological therapy that focused on psychodiagnostics, cognitive behavioral therapy, and the acquirement and modification of habits. And this was very similar to the postoperative care, with again that idea of 1 year being considered adequate. And this description of psychological therapy is quite frustrating coming from a psychology perspective, as although it sort of has really good potential in terms of highlighting that use of CBT and being something that is quite well evidence-based in terms of an approach, they haven't described in any detail what they're doing specifically within CBT and what would be included within these sessions. So this is quite similar to saying something like, I performed bariatric surgery on that patient without giving any idea of the specific procedure that you did, how long it took, if there were any complications, what postoperative care would be needed. So it's really challenging to kind of understand exactly what was done within this psychological intervention from this description alone. And they also haven't provided more sort of nuanced details in terms of the number of sessions, the length of the sessions, again, what the content was and what modalities they might be using, which makes it very challenging for us to understand in any detail what this psychological intervention actually included. Nonetheless, if we move on to the results, 79% of patients were under psychological treatment during the postoperative period, and the mean treatment time was 2.4 years. So in terms of the outcome excess weight, if we look at this top table here, we can see that patients who had psychological therapy experienced a weight loss of over 50% of their initial weight compared to those who didn't. And as we can see here, this was a statistically significant difference in years 1, 2, and 5, but not 3. And looking at the outcome of weight regain, we can see that a higher percentage of patients who had psychological therapy experienced less weight regain than patients who didn't. And we can see that this was a statistically significant difference in years 2 and 5, but not 1 and 3. So kind of top level understanding of these results, they're suggesting that patients who had the psychological intervention experienced higher excess weight loss and lower weight regain. And I just wanted to highlight one of the figures that was included within this paper. So here they're looking at the weight regain outcome. And we can see that although they reported their sample size to be 100, when these patients are divided out into the different time points, we can actually see that the sample sizes are quite small. So if we look at the data for the second year, for example, where they reported a statistically significant difference, you can see that for patients without therapy, this group was less than 20, and for patients with therapy, this group was less than 5. So we're looking at very, very small sample sizes here. So in terms of the discussion and conclusions, so this is what the authors have concluded from their own in patients who underwent gain after 3 years and late regain after 5 years appears in most patients, but is higher in those treatment. And they also suggest that this paper emphasizes the importance of psychology applied to bariatric surgery and opens the door for behavioral therapy for interventions for patients with weight regain. So as I said at the beginning of the presentation, we're now going to go on to thinking about some of the strengths and limitations of this paper. But we sort of concluded that based on the methodological limitations that we've identified, these conclusions are perhaps a bit strong. So moving on to the strengths of the study. Firstly, they did conduct a longitudinal analysis across 4 time points, which is very challenging, particularly within a clinical setting. So this is a real strength of this study. And they also explored the importance of post-operative psychological support, which, as I mentioned at the beginning, is a topic that there's generally less focus on as compared to the preoperative assessment. So that is another strength. However, if we think about limitations, some of these I've touched on previously, but just to highlight them again. So they did have a very limited sample size, particularly when we're thinking about when patients are divided up into those 4 time points. And linked to this point, they did not provide a power calculation. So we don't have an understanding of if the sample size that they had was actually enough to have a high probability of detecting a true effect if it does exist. They also used a retrospective observational design, which meant that they couldn't, for example, manipulate the predictor variable, so manipulate that psychological intervention to think about whether certain modalities or content may have had different effects on weight outcomes. And it may also be this retrospective design that led to the kind of vagueness in that description of the psychological intervention, because they would have only been able to base what was done with these patients in the sessions on medical notes or case notes, which could be tricky to sort of decipher what was actually done within those sessions. There's also a lack of generalizability because this was a very small sample in a very in Argentina, and they also interestingly didn't report our understanding of the sample within the study here. And linked to this, they also didn't look factors other than age. So they did look at age in terms of the relationship between age and weight outcomes, and they didn't find any significant differences there. But they could have looked at other variables such as ethnicity, gender, and socioeconomic status in order for us to have a better understanding of, firstly, what did the sample look like and who was included within this study, but also if any of those factors had an influence on the weight outcomes that they were interested in. As I've touched on in quite a lot of detail, the psychological intervention that they described is quite vague in terms of the content, but also the timings of the interventions. So they mentioned that the mean treatment time was 2.4 years, which is quite a long time for psychological intervention. And we don't actually know during this psychological follow-up how often patients were having sessions. It could have been weekly, it could have been yearly, and this would significantly affect how we would understand the intervention and what we would sort of take away from that. They also didn't collect any data on mental health outcomes, and this could have been things such as low mood or symptoms of generalized anxiety. And this would have really allowed us to understand if there was any relationship between certain symptoms or certain presentations and those weight outcomes. But again, this is a limitation of the retrospective design, because if that data was not collected at the time, then we wouldn't have that information. They also don't take into account in this study the idea of disengagement, and that patients who would perhaps be struggling the most post-surgery would disengage from psychological support and would therefore have worse weight outcomes. So that wasn't touched on or taken into account within the results. And finally, they didn't detail the type of bariatric procedures that were done on these patients. They simply stated that patients had bariatric surgery. So that would obviously have a potential impact on their weight outcomes and also their psychological outcomes as well. So some final thoughts on this study. It introduces the idea of post-operative psychological support as an important part of the bariatric pathway, and the idea that this support potentially leads to improved long-term weight outcomes. However, we concluded that the scientific integrity of this paper significantly limits the conclusions that can be drawn from this data alone. But I do think that the paper highlights a really important area, and the fact that we should be thinking about shifting the focus from pre-surgical assessment, which is obviously an important part of the bariatric pathway, but also thinking about what we can do to support patients post-operatively as well. Thank you for listening.
Thank you so much, Olivia, for choosing this topic and for the excellent presentation. Very well done.
Thank you.
Very, very interesting topic, to be honest with you. We have a couple of questions, and then I would like to ask Emily with us today, psychologist and Lewisham and the clinical lecturer, to comment as well on this paper. So I have a question. I wonder whether the intervention was individual or group. Group psychological interventions can be very effective with bariatric patients. Olivia, this for you.
Interesting idea, Josie. And they didn't actually specify whether they did a group or an individual intervention, sort of how they didn't describe in much detail the psychological intervention and what was included there.
Okay, thank you. Another question. Did the authors give any explanation for why some patients opted in for post-surgery psychological support or opt out of the support?
No, so unfortunately, again, they didn't give any explanation as to why some patients opted in or out. And I think that was one of our sort of discussion points within the limitations, thinking about what patients are more likely to disengage from psychological support, and the idea that perhaps those who are struggling more may actually disengage. So yeah, it's an important thing that was not considered within this paper.
Okay, another question. I would be interested to know what percentage of bariatric psychologists' time is pre-surgery focused and percentage post-surgery support. Can you comment what is in your service?
Yeah, and I might ask Emily to come in a little bit on this one. I think I think in terms of our service, in terms of Emily's work, there's a lot of focus on the pre-surgical assessment and also a small number of one-to-one cases. And we are also going to be bringing in a bariatric support group, which has run within the service before, and that will sort of provide patients, I guess, lower level support for those who don't have more complex sort of psychological presentations, but would benefit from support. But Emily, perhaps you'd like to comment as well.
I think, Olivia, you've summarised it well. Most of our attention is pre-operative, as is often the case with limited resources, but we do see people post-operatively. Usually that's when something has been really quite complex. And I think there's quite a difference between optimizing through psychological support post-operatively versus seeing someone as a psychologist when things have gone wrong. I know that varies very much across different services depending on resource available. But yeah, mostly pre-op, some post-op.
Okay. Thank you. Do you think we need like a certain criteria for who needs to be followed post-operatively, or do we have any specific criteria who to follow after the operation?
I think it's a tricky one, given we don't particularly know from what predicts outcomes over time. So pre-operative predictors are notoriously not very strong at looking at that. There probably are markers, and I think that's where we can draw on really big data sets in terms of longitudinal. But I guess going back to Olivia's point, there certainly have been studies that have looked post-operatively, but it's far fewer. So it's a really good research question that I think we should be looking at more.
Okay, thank you so much. We have 2 more questions, but I will move on to the second presentation for the sake of time. So for Mr. Mamdana, if you want to introduce your second speaker, please.
Thank you very much, Olivia. That was great. Our next paper is the surgical paper, which is going to be presented by Ellen Jerome, who's a senior trainee with upper GI and bariatrics interest. And she's going to try and address the age-old question of which is better, sleeve or bypass, with the longer-term outcomes from the BOMSS study. So, Ellen, over to you.
Thank you very much. Hi, everyone. My name's Ellen Jerome. Thanks for having me here. So yeah, presenting a paper today, the long-term outcomes of laparoscopic rheumatoid bypass versus sleeve gastrectomy for obesity, and it's the BOMSS randomized control trial. This paper was published online on the 19th of February this year in JAMA Surgery, the journal, the American Medical Association, which is the highest impact factor surgical journal, internationally impact factor of 15.9. Which is the surgical part of the American JAMA network. 59% of submissions to the paper, though, are from outside of the USA. Why did I think it was significant to look at this paper? As Mr. Mamdana alluded, it's a question that we all ask for when we're seeing our patients, whether we're going to consider them for sleeve gastrectomy or bypass surgery. And we often required to counsel patients on what their preferred procedure is going to be, what we think the outcomes might be, and use that to guide their decision making, which a lot for compared to other surgeries lies with them. There's a relative paucity of randomized control trial data. I know bypass sleeve was published in the Lancet just a few days ago. And we've got the follow-up data to 3 years from that study at the moment. But that longer-term follow-up randomized data, there's not lots out there. And, you know, knowing how patients are going to be affected longer-term in today's setting, I think is important. And there is a trend that we see in our daily operating list, and we see that on the IFSO registry and NBSR towards more and more patients having sleeve gastrectomy when they're coming for surgery. So knowing long-term how those choices are affecting our patients as we use the operation more and more. And then the reporting of this paper on weight regain, de novo gastroesophageal reflux disease, and reoperation rates. So that's why I've decided to present it today. As a background, this study is the Swiss multi-center bypass or sleeve study, or SMBOSS. It was initially presented back in 2018, again in JAMA. JAMA surgery, and it was a 2-group randomized controlled trial where patients in Switzerland were randomized to sleeve gastrectomy or Roux-en-Y gastric bypass. The 5-year results were published back in 2018, and this showed no difference in what they report as excess BMI loss between the 2 patient groups, and no significant difference at that time in reoperation rates. Patients were recruited between January 2007 and November 2011 at 4 centres in Switzerland. Of about 3,000 patients screened, 117 participants were included, and amongst inclusion criteria, patients had to be between 18 and 65 years, have a body mass index greater than 40 or greater than 35 with one weight-related comorbidity, so fairly similar to a lot of the patients we're seeing in the NHS, but quite a while ago. And exclusion criteria, any patient who had previous bariatric surgery, any patient with severe gastroesophageal reflux disease, any patient with large hiatal hernias, and any patient with inflammatory bowel disease, so quite broad inclusion criteria. Block randomization was performed centrally, computer-based, to randomize patients to each treatment group. Each patient went through a preoperative MDT assessment and upper GI endoscopy before proceeding to surgery. And the interventions were standardized by the sleeve gastrectomy performed over a 35 French bougie, 3 to 6 centimeters proximal to the pylorus. Roux-en-Y gastric bypass was standardized by 150 centimeter anticolic roux limb, 50 centimeter biliopancreatic limb, and there was full consort reporting for all throughout the study. Oops. The endpoints that they looked at, so their primary endpoint was percentage of excess BMI loss rather than weight loss, and suboptimal weight loss was defined as less than 20% of total body weight loss. So percentage of total body weight loss was also reported, and they describe recurrent weight regain as greater than 30% from their maximum weight loss. Secondary endpoints, looking at the percentage of total body weight loss, the change in BMI, evolution of obesity-related diseases, so whether we saw remission of diseases such as type 2 diabetes, dyslipidemia, gastroesophageal reflux, hypertension, and sleep apnea. So all the things that we know that our weight loss surgery is good for. And there were quality of life was studied using standardized reporting outcomes, which weren't really reported in this paper, so I won't go into. In the primary study, they did a power calculation which suggested a sample size of 100 patients per group should provide a powerful power to reject the null hypothesis. The patient groups were analysed using intention to treat analysis in all those who were randomised. And this paper reports per protocol analysis for any patients who completed the protocol at 10 years, okay, and that was a 10-year point. So that was out without any treatment conversion before then. Of 3,971 patients screened, 225 were randomised, and at 10 years there was complete follow-up for 142 of those participants. 61 were male, 156 female, so female predominance, and the mean age was 42 years, standard deviation of 11 years. Of the patients included in this study, 69 underwent sleeve gastrectomy and 73 underwent Roux-en-Y gastric bypass. So looking at table 1 and the main results, as we know already, both operations did give clinically significant weight loss, which the paper defined as more than 10% of excess BMI loss. So we're seeing 60.6% excess BMI loss amongst the sleeve gastrectomy group and 65.2% within the Roux-en-Y gastric bypass group. But again, as with the first paper, we did not achieve any statistical significance between the two groups. So total weight loss, BMI loss, and excess weight loss was not statistically different between the two groups in the intention to treat analysis. Looking at the per protocol analysis, and we've got significant dropout in the sleeve gastrectomy group at 10 years. Again, good weight loss in both groups, but no statistical difference between sleeve gastrectomy and Roux-en-Y gastric bypass. And what the paper highlighted in the abstract and in their poster reporting is that sleeve gastrectomy patients achieved 56.1% excess BMI loss per protocol compared to 65.9% excess BMI loss in Roux-en-Y gastric bypass. So they're suggesting that the superior outcomes that we know about already from other research in the Roux-en-Y gastric bypass group, but non-significant within this paper. And these are the broader graphs showing the weight loss outcomes, and we're seeing the plotted means, but there is obviously a wide spread of data that we should be counselling our patients for. Of the secondary outcomes for all the other weight-related diseases, type 2 diabetes, hypertension, dyslipidemia, sleep apnea, and reflux, there was no statistical difference between the two groups. But the one thing that is of interest, I think, in this paper is looking at the gastroesophageal reflux symptoms, and of patients who did not have any symptoms at baseline entering the study. De novo symptoms were seen much more frequently among the sleeve gastrectomy patients, the 11 patients here, and compared to the Roux-en-Y gastric bypass patients. So both groups saw some remission of symptoms in patients who had reflux symptoms at presentation and at recruitment to the trial, but there was quite a lot of high rate of de novo symptoms in the sleeve gastrectomy group, and this did achieve statistical significance, although the patient numbers are still small. What I did think was interesting in this paper is they presented this survival chart, Kaplan-Meier chart, showing the dropout rate or crossover for patients who underwent revisional surgery. So those patients who were excluded from the intention to treat analysis, sorry, the per protocol analysis. And when we look at this graph, we're now analysing the patients at 10 years, so quite a high crossover rate, about 25% or so. But at 14 and 16 years, where the follow-up ended, about 65% of patients, about 60%, sorry, of patients within the sleeve gastrectomy group had revisional surgery. Looking at the sleeve gastrectomy group, 32 of the initial 107 underwent revisional surgery. 46.9% of these patients were due to reflux symptoms, and 28.1% were due to suboptimal weight loss. 18.8% had a mixed picture between reflux and suboptimal weight loss, and 6.3% due to stricture. Of those, 6 of 110 patients who were randomized to Roux-en-Y gastric bypass, all of them had revisional surgery due to suboptimal weight loss, and they had a mixture of BP limb lengthening and other procedures, pouch revision. So what does this paper tell us? There's no real significant difference between these two groups in this paper at 10 years, and that reflects the findings at 5 years. And it doesn't demonstrate any weight-related disease outcomes, which shouldn't, influence our decision-making for metabolic surgery if we were to refer to this paper. What it does show is there's a very significant rate of new reflux symptoms in the sleeve gastrectomy group, which can be useful if we're counselling patients planning for surgery. And there's a very high rate of conversion or revisional surgery in the sleeve gastrectomy group. Okay, again, useful when counselling our patients and choosing a metabolic procedure. Why the study limitations? I think it's obvious that this patient was not powered to detect differences that we've seen in subsequent research. BioBand sleeve is a good example to look at weight loss differences and weight-related outcomes, because the results do suggest that, but it's not powered to find significance. there's quite a significant loss to follow-up for these patients and a high conversion rate that cannot be analysed. And these similar sleeve pass study was conducted in Finland and reported similar outcomes. And so these data have been pooled from these two studies, which are fairly similar. Further research and how we can make sense of this data. I think it's interesting in the sense that, you know, I don't think it tells us in terms of weight loss how patients can choose surgery and how we can counsel them or have shared decision making. And I think we've got that data from newer research such as the BIPAN sleeve study, and we will wait to see what the longer term follow-up results are when that comes around. But it does help us, you know, share those decisions with patients and know that within the NHS and the constraints we're working under, we've got one chance, one bite of the cherry to do the right operation for the patient. And so many of them come to see us with their own views on what they want, often towards a sleeve gastrectomy, and knowing that, you know, how we're seeing suboptimal weight loss and high reflux symptoms, that might help patients make different choices if they've only got one opportunity to have a weight loss operation within our healthcare system. I think we need to do further research to look at the impact of obesity management medications on our practice and decision making for sleeves and bypasses. These data are from, you know, all the way back in 2007 when I was leaving school, and you know, we're in a completely different world right now, and we're seeing how obesity management medications affect decision making on our practice. And so I think, you know, we could always learn from qualitative research into those decisions when patients are choosing metabolic procedures. That's all good. Thank you.
Thank you so much, Ellen, for your excellent presentation and bringing up this topic. So I have a question from the floor first. Did they define severe GERD in this paper, actually?
I don't think so. No. They
just mentioned, sorry to interrupt, Ellen. They just mentioned that severe GERD was persistence of symptoms despite being on medications. So a loose definition.
Okay, I'm just not responding to PPI. Okay, so a question from my side. What do you think with the high conversion rate or this conversion rate of sleeve gastrectomy on the long term? Do you think we should be offering at some point medications versus Roux-en-Y gastric bypass? CO from Mr. Mamidana. Thoughts, just thoughts.
I think well, I think that's, you know, what we will see, and patients are choosing that themselves. So we're seeing some patients who have suboptimal weight loss can't yet access OMMs within the NHS and are going out and buying them, and you know, that's a good option for them because if they're not, you know, suffering with reflux but they want to lose more weight, then they avoid going through another operation, which, you know, may be good in the short term. We don't know, again, the longer term outcomes. And as patents change and as drug availability increases, I know that, you know, commissioners are going to provide more and more of these medications to our patients before they come to our door. So, you know, I think avoiding surgery may be bad for business, but it's good for patients. So I definitely think it should be part of, you know, it would be nice if we can access it as part of our practice rather than it coming elsewhere.
Okay, Mr. Mamidana, any comments from your side?
Thanks, Ellen, for that. I think it boils down to the system we are in, isn't it? The health infrastructure. So we are different to America or Europe, and where these trial data come from, patients have access to unlimited number of surgeries. So if we are going to sit a patient down in our clinic and say you're eligible for one operation on the NHS, they will say which is the best one for me. And then are you going to say, despite all this data, that you can have a sleeve? Whereas somewhere else you can say, yeah, have a sleeve first, see how you do. If you've got reflux, we'll change it. If you've got, you know, not enough weight loss or weight regain, we'll change it to something else. So it depends on where you're working, and what access you've got. It'll be interesting to see what happens to buy-band sleeve data at 10 years, whether it still sticks to their 3-year outcomes, because SMBOSS in their 5 years did not find a difference, and at 10 years they found a difference. So that'll be a very interesting finding and probably more applicable to our practice.
Thank you. Thank you. We have a comment here from the floor as well about doing sleeve as the first step, because if it fails, if Roux-en-Y gastric bypass fails, there's no real effective revisional surgery. Probably may change the limb lengths, and that's it. Any comments from your side, Mr. Mamidan or Ellen?
Again, it comes to where you're working, isn't it? So it would make sense for a young person to start off with the sleeve, knowing that there are options in the future. Whereas if we start giving Roux-en-Y to all patients here on the NHS now, what happens for the percentage of people who've got suboptimal weight loss or even weight regain? So they're kind of stuck. The OMMs might help in that case. But then if you look at Olivier's paper, then we ideally need a randomized trial that looks at weight regain and weight loss with regular psychology follow-up and input. And then we see if there's a difference between sleeve and a bypass, if both the patients are getting the psychology support. Because what happens in the MDT when you see a patient with weight regain, the first question is, see the dietitian, see a psychologist, let's see if you've got disordered eating or not. So instead of making that therapeutic, why don't we make it prophylactic? So if we have all our patients getting regular post-operative psychology input, whether it's for 1 year or 2 years, we might not see the suboptimal weight loss, or we might see less of it.
Yeah, thank you. Well, I completely agree with you. And we'll see in the future what happens. So the NHS, there's a 12 years plan to roll out Mounjaro in the market. So we'll see what happens in, in the coming 12 years and the effect on bariatric surgery. We have a question for Emily here, which is the bariatric support group open to all patients or those that require psychological support? I'm not sure, Emily is still on the call.
I am. So our bariatric support group is very deliberately open to all patients. So the function, I guess, of support versus psychological intervention is quite distinct. And we wanted to make this as open and inclusive to, I guess, that difference of how do we help and support and optimize outcomes for people who are going through behavior changes, which are difficult regardless of mental health, which is quite different and distinguished to those who are struggling with severe mental health issues or mental health issues or behavioral issues that may be interfering with outcomes. So yeah, overall support groups, everyone would be lovely to also have a psychological treatment group, which would be separate for people struggling.
Thank you. I have a question here from Alan. Are we concentrating on that wrong topic here? Should our focus be more on lifestyle and diet behavioral therapy, post-operative, rather than sleep versus Roux-en-Y gastric bypass? Mr. Mamdana, what do you think?
Yeah, I mean that's what I was just alluding to before, isn't it? We need a trial that looks at these operations in presence of all the psychology support as well as dietetic support. So we might find that both surgeries work equally well if the patients are well supported in the post-operative periods, not just the operative intervention. And also, just going back to your previous question about identifying which patients require this support. I mean, we don't have criteria for who gets a surgical follow-up, do we? We don't have criteria for who gets a dietetic follow-up. Everyone gets it. So why do we need criteria for who gets a psychological follow-up? So I think they all deserve it. They all need it. Yes, we make criteria because of the restrictions on the availability of resources. But in an ideal world, they should get all of our support, and then I'm pretty sure the outcomes will be really good, independent of the type of surgery.
Thank you. We have one last question. It's actually for Olivia. Was there any data related to the type of bariatric procedure performed and the continuation of follow-up?
No, there wasn't. bariatric surgery was carried out, and I think it links to Ravi and Ellen's paper. You know, they didn't specify the type of surgery that was conducted. So yeah, I think there's definitely some room for combining these two, kind of thinking about different.
I think your line is breaking. Okay, so okay. So okay, we didn't hear the last couple of minutes that you said, Olivia, sorry.
Oh, sorry, I don't know what bit I cut out, but
Okay.
yeah,
it's
they
not,
didn't
they didn't
specify
mention.
what type of
Okay, thank you, Olivia, and thank you, everyone. This concludes the Journal Club tonight. Thank you, everyone, for your excellent presentations. And we'll see you next month in the next Journal Club. Thank you, everyone.